Hello everyone, this is the Dr. Madhusudan Rao and the program I teach medical students. In today's lecture, I'm going to talk about Babinski reflex. Babinski reflex is one of the most important clinical signs we are going to elicit during the examination of the central nervous system. It will identify the integrity of the corticospinal tracts, that is the motor tracts running from the cerebral cortex down to the spinal cord. That is, it will identify the upper motor neuron lesion. So, okay, we are going to talk about this topic in the lines to know how to perform the Babinski test, to describe anatomical and physiological pathways, and to discuss the clinical relevance of Babinski tests. They are the objectives of today's lecture. Babinski's sign or Babinski reflex test was first described by a neurologist Joseph Babinski in 1896. Since then, it has been used as a part of the neurological examination. It is a simple test that does not require costly equipment or patient's cooperation. Well, stimulation of the lateral part of the sole will elicit a response. The test is positive when there is a dorsiflexion of the great toe with the fanning of the rest of the toes. Okay. This reflex test does not require active participation of the patient. Okay. So this test, the patient's cooperation is not required. Neither we require the costly equipment. It is a simple test that is done at the bedside to elicit to examine the most important functionality of the corticospinal tracts. Coming to the anatomy and physiological aspects of this particular test. Babinski reflex is used to test the integrity of the corticospinal tract. What is corticospinal tract? These are the fibers that run from the cell bodies which are located in the cerebral cortex in the motor area. Okay. They run downwards through the internal capsule via the brainstem and enter the spinal cord, crossing to the opposite side at the lower border of the medulla at the level of the pyramids, and innervate the anterior horn cells of the spinal cord. Okay. They are called the upper motor neurons. Upper motor neurons, they have the cell bodies in the motor cortex of this cerebral hemisphere, and from that point down to the anterior horn cells, they are called the upper motor neurons. The alpha neurons of the anterior horn cell and their axons from the point of the anterior horn cells to the point of neuromuscular junction, they are called the lower motor neurons. Babinski test will give you the information about the integrity of the upper motor neurons. Okay, that is corticospinal tract. The fibers of the corticospinal tract have their cell bodies, as I told you, in the primary motor area and innervate the cell bodies of alpha motor neurons in the anterior horn cells of the spinal cord on the opposite side. The fibers of corticospinal tract are the upper motor neurons, and those of the alpha motor neurons constitute the lower motor neurons. Okay, that is, alpha motor neurons from the spinal cord to the neuromotor junction, they form the lower motor neurons. How to perform the Babinski reflex test? Stimulate the lateral border of the sole using blunt object from heel to the base of the little toe. Okay. Drag the blunt object from the lateral border of the sole to the base of the little toe and continue to the base of the great toe. Okay. Well, that means you are stimulating the receptors of S1 dermatome. That is the S1 dermatome that is located in the lateral border of the sole. That is, sole is, spinal segment is S1. The receptors, nociceptors at the S1 dermatome are stimulated. They carry the signals along the tibial and sciatic nerves to the S1 segment of the spinal cord. Okay? And there they synapse the anterior horn cells of the S1 myotome. Axons of the alpha neurons from the anterior horn cell, they enter the anterior root of the spinal cord. Okay? Okay? And the motor response is flexion of the great toe that is mediated through the S1 anterior spinal root through the tibial nerve. That means anterior horn cells that are located in the S1 segment of the spinal cord, they run in the anterior root of the spinal cord, enter the peripheral nerve, and through the tibial nerve it innervate the muscles of the foot. That is flexors of the foot. That is ankle flexors. That results in the response is characterized by there will be curling of the toes with flexion of the great toe as a normal response. Okay. What is the pathway? You are stimulating the lateral border of the sole. That means you are stimulating the nociceptors in the S1 dermatome, which carry the signals to the S1 segment of the spinal cord. They have make the synapse with the anterior horn cells. From there, efferents run into the anterior root of the spinal cord. Okay, enter the tibial nerve, innervate the flexors of the ankle, and the response will be the flexion of the great toe with curling of the toes downwards. Okay, there will be curling of the toes with flexion of the great toe as a normal response. Supposing if there is no response, that is considered as neutral response. Okay. Well, it does not carry any clinical significance, but cannot rule out any pathology. So when there is no response, you have to do the alternate tests. There are tests alternative to the Babinski response. Though they have to be performed in order to look for the response. Sometimes, when the sole is thick and barefoot walkers and the degree of intensity of the stimulation is weak, you may not be able to get the response. But when the response is blunted, you have to do the alternative procedures. Well, when the situation when you suspect the injury to the corticospinal tracts, when the regular Babinski reflex, you cannot get a response, you go with the other methods of testing for plantar reflex. The intact corticospinal fibers. That is, when the corticospinal fibers are intact, okay, they inhibit the spread of the sensory signals beyond S1 segment. Okay, when you are stimulating the lateral part of the foot, you are stimulating the S1 dermatome, right? And the signals that are reaching the spinal cord, they remain at this S1 segment level only in the presence of inhibition by the corticospinal tracts. When the inhibition from the corticospinal tract is lost, okay, that the stimulus will spread to the area beyond S1 segment. That means the lesion, if there is lesions of the corticospinal fibers, the inhibition is lost and the sensory stimulus can extend to L5 or L4, LL3 beyond. Okay. Then the efferents travel in the peroneal nerve to innervate the extensors, that is extensor hallucis longus and extensor digitorum longus, thereby resulting in the extensor response of Babinski reflex. Okay. That means the stimulus signals you are sending, they should be inhibited and limited to the stimulation of the particular segment. That is S1 segment. If there is no inhibition from the corticospinal fibers, the stimulus will be extended to the other segments like beyond the S1, that is S5, S4, S3, like that. And the returning signals, they go through the peripheral nerve that cause the extensor response, that is the deep peroneal nerve, which innervates the extensors of the foot, resulting in extensor response. So this is what it is. Normally it is flexor response because signals from the S1 dermatome stimulates the anterior horn cells of the S1 segment. From there, reference in the anterior root of the spinal cord, then enter the tibial nerve and cause the flexor response. Okay, when the inhibition is lost due to the corticospinal fibers injury, the signal you are sending from the stimulation of the sole, okay, it will not only stimulate this S1 segment, also stimulates the S5 and S4, S3, etc., thereby resulting the widespread stimulation of the anterior horn cells, thereby resulting in the extensor response. Because extensors are stimulated, thereby resulting in the efferents causing the contraction of the extensor hallucis longus or extensor digitorum longus, thereby causing the extension of the great toe and fanning of the other toes. Okay, this shows, that means this clearly shows there is injury to the corticospinal fibers and the inhibition from these upper motor neurons is lost. That is why signals that are initiated through the stimulation of the sole, they are causing the resulting in the widespread stimulation of the other segments, thereby resulting in the extensor response. Okay, this is what happens in pathological conditions of corticospinal fiber lesions, resulting in the extensor Babinski reflex. Then what is Babinski sign? Babinski sign occurs with the extension of great toe and fanning of the other toes when the lateral border of the sole is stimulated. Babinski reflex is, it constitutes reflex arc. That is the afferents from the S1 segment sole dermatomeria is stimulated. They go to the center, that is the S1 segment of the spinal cord, and there is synapse between the afferent and the anterior cells, that is alpha motor neuron is stimulated, and the efferents run in the anterior root of the spinal cord via the tibial nerve, thereby causing the flexion of the great toe with the curling of the other toes. This is the normal response. When there is the injury to the corticospinal fibers, the stimulus that you are giving at the S1 dermatome, it is not confined to the S1 segment, it will spread to the other segments, stimulating the anterior horn cells of the other segments. That is, it could be S5 or S4, and the returning signal, that is the efferent signal, is going to cause the extensor response because of the contraction of the extensor hallucis longus and extensor digitorum longus, which are innervated by the deep peroneal nerves. Their root value being S4 and S5. Okay, instead of getting the referent signal from the S5 segment, we are getting the efferent signal from the L5 and S5 and S4 through the deep peroneal nerve, thereby resulting in the extensor response of the Babinski reflex due to the stimulation of the extensor hallucis longus, extensor digitorum longus. Okay, this is what happens in the pathological conditions due to the lesion of the corticospinal fibers. That is the positive Babinski sign. Babinski sign occurs when the extension of the great toe and fanning of the other toes when the lateral part of the sole is stimulated. This means there is spread of the sensory stimulus beyond the S1 segment to S5 and S4 myotomes. If CST is intact, this will not happen. This spread will not happen. The stimulus will remain at the level of S1 only. Okay, because there is injury to the CST, there is spread of the sensory stimulus beyond S1 segment and stimulating the S5 and S4 myotomes. Babinski response is extensor in infants till the age of 24 months. Okay, because myelination at that below that age is incomplete, and you get the extensor response. Again, Babinski is extensor during sleep and when the patient is in coma. Okay. What are the indications? So Babinski reflex is done as a part of the clinical examination of the central nervous system. Oh, from the age-old times, and the Babinski reflex was identified in 1896. Any suspected injury to the CST tract, that is corticospinal tract, you have to institute the Babinski reflex test. Yes, this is the early indicator of CST dysfunction in stroke and spinal cord injuries. Okay, when you suspect following a trauma, the patient comes to the emergency, you do the Babinski test. That is the earliest clinical test you can get a response, which may be diagnostic of injury to the corticospinal tracts. What are the there are such no contraindications except if there is a infection at the site of stimulation to test the Babinski response. So in these situations, do the alternative methods like Shattuck, like open hymns, like Gardens, which we are going to touch briefly in the coming slides. What is the equipment you use for the Babinski test? Any blunt object can be used. Okay, you can use the reflex hammer. It's the dull point. Okay, you can use the tongue depressor. You can use the tip of your key, or you can use a coin. How to prepare the patient? Let the patient remain relaxed. Okay, explain the process of the test you are going to do. Also explain the patient that he may experience some discomfort or tickling sensation when you are stimulating the body of the soul. Technique of the test. The instrument to elicit the reflex is run along the lateral side of the sole from heel to the base of the little toe. Okay. Continue drag on the metatarsophalangeal metatarsophalangeal prominences you see to the base of the great toe. You can arch the stimulus. You give a stroke at the lateral part of the sole to the base of the little toe. That's enough. In some textbooks, they say you continue stimulating the metatarsophalangeal junctions, continue to the base of the great toe. You can do that also. Okay, that will trigger the response. In normal individual, there is a flexion of the toes. The alternative methods that are used when that particular area is not hygienic, it is infected or something like that. Take the Shardak, where you stimulate the dorsum of the foot just below the lateral malleolus, and you get the same response. Gordon, by squeezing the gastrocnemius or tender Achilles, you can get the response. Open hips, just stimulating the shin of the tibia from knee to the ankle. You'll get the response as you see in the routine Babinski test. What is the clinical significance? Presence of dorsiflexion of the great toe with fanning of the other toes is indicative of positive Babinski sign. Babinski reflex test is negative if the response is flexion of the great toe and curling of the other toes. That indicates Babinski reflex test is negative. Babinski is absent, like that. Okay, that tell you about the integrity of the corticospinal tracts, which are intact. Absence of any movement is considered as neutral. Okay. When there is positive response in the form of the extension of the dorsiflexion of the great toe with the fanning of the other toes, it indicates there is injury to the corticospinal tract from any point, that is upper motor neuron lesion, any point from its cell bodies in the motor cortex down to the anterior horn cells. Absence of any movement is considered as neutral, but we cannot exclude the pathological lesion. You have to thoroughly examine for the other clinical signs and do the alternative methods of Babinski test. Okay. What are you going to do in comatose patients? In comatose patients, the patients are in deep sleep. The response of the Babinski test is extensor. Okay. But in comatose patients, you may get the extensor response, but you have to identify the presence of corticospinal tract injury. Okay. For that reason, you can go for triple flexor response. You have to look for the triple flexor response after giving a stimulus to the sole of the foot, which includes Triple flexor response includes dorsiflexion of the ankle, flexion at the knee, and flexion at the hip. This is a mass response. This indicates gross dysfunction of corticospinal tracts. Okay. This can be confused with withdrawal response. Withdrawal response is also violent withdrawal of the limb when you are giving a stimulus to the sole of the foot. Withdrawal response is not consistent. The range of the flexion at the knee is variable, the range of the flexion at the hip is variable, and the foot movement is variable. It is not similar every time when you stimulate the sole. Okay. Whereas triple flexor response is stereotypic. Right? This is the difference. I'll show some quick pictures where the Babinski reflex test is performed. This is the normal plantar response. So when you are dragging this with a blunt object at the sole from the base of the heel, from the heel down to the base of the toes, there is flexion of the great toe with curling of the other toes. Then this picture shows the Babinski sign being positive. Extensor plantar response following stimulation of the S1 dermatome. There is extension of the great toe with fanning of the other toes. Okay. This picture also shows is similar to the earlier picture. This again the Babinski sign. So he is stimulated the sole from the lateral to the base of the toes, and you see the extension of the toes with fanning of the other toes. This is Shardak reflex alternative to Babinski response. He has stimulated the area here below the lateral malleolus from the heel to the dorsum of the heel to the base of the toes. This is where he has stimulated. This is the area he has stimulated, and he got the response of extension of the great toe with fanning of the other toes. This is the Gordon reflex. He is trying to squeeze the calf muscle, then he got an extensor response of the great toe with fanning of the other toes. So these are the alternative methods of getting the extensor plantar response when the Babinski test could not be performed. This is a Hoffman's sign, Babinski of the upper extremities. This is again for test for the upper motor neuron lesion. Flick the middle finger. Watch for the reflex flexion and reduction of the thumb. Okay. This is the Wattenberg sign. Again, the alternative test for the Babinski sign. Sort of the Babinski equivalent in the upper limbs. So this is all about the Babinski reflex test, Babinski sign, and its interpretation and its importance to identify early the lesion in the corticospinal tracts. This is how the integrity of the corticospinal tracts is identified through Babinski test response. And we have mentioned some of the alternatives to Babinski test. And that is the Shardak, Hoffman, and Gordon. And the equivalents in the upper limb are being the Hoffman and Wattenberg. Thank you for patient listening, and we'll meet you again in the next class. Until that time, bye bye.